Hello, I am Madhuri Josna from the Nizam Institute of Medical Sciences, Hyderabad, India. Today we are going to present an interesting case of acute coronary syndrome complicated by pseudoaneurysm. I will request my colleague Dr. Lalita to give the details of the case.
The patient is a 69-year-old male. He is a diabetic and a hypertensive and presented with chronic stable angina in 2006. In 2006, PTCA to left anterior descending was done with a bare metal stent. He again presented with chronic stable angina in 2009 and an angiogram done then revealed instant restenosis of the LAD stent. PTCA to LAD was done with a drug-eluting stent. He presented in December 2013 with unstable angina and a repeat angiogram showed single vessel disease involving the LAD. The LAD had 80% osteoproximal lesion with minimal instant luminal loss. CABG was done with Lima to LAD graft.
This time, patient is presented with a rest episode of angina in March 2014 with ECG changes. Echo revealed regional wall motion abnormality in the LAD territory with a mild LV systolic dysfunction. Patient was stabilized with tyrosine infusion along with a loading dose of dual antiplatelet therapy before referring to this hospital as that hospital doesn't have a PCI facility. Coronary angiogram is done through the right femoral root. Codominant circ has a minimal disease. Stent in LAD is a patent. Ostial LAD demonstrated the tight stenosis. This is RAO cranial view. Codominant RCA also showed the mild disease. Lima graft is patent, but this is anastomosed to the distal diagonal branch, but not to the LAD. Post-angiogram, patient developed 5.3 into 4.8 cm pseudoaneurysm with a 6 mm neck and surrounding a big hematoma at the right femoral puncture site with a significant hemoglobin drop.
Patient received 3 blood transfusions, anti-anginals in view of his rest angina and decongestive therapy with continuation of dual antiplatelet therapy. In hospital, the patient had another episode of rest angina with ST depressions in anterior leads along with LVF, which was controlled. CT angiogram confirmed our diagnosis of a pseudoaneurysm with a large hematoma. Urgent vascular surgeon help was taken for pseudoaneurysm repair and evacuation of the hematoma.
So immediately we taken the patient for the PCI to the LAD, and during the PCI the major problems we encounter is the first thing is vascular site complications complicating the unstable nature of the patient, and the second one is what vascular site we have to take the patient and how effectively we can do the PCI in this. So actually the major problem in this patient is not only the pseudoaneurysm repair from the right femoral artery, but unfortunately we have asymptomatic occlusion of the right radial artery. The leftover access for us is left radial artery and left femoral artery. To add it to that problem, we have a very complex proximal LAD lesion. So finally we decided to go through the left femoral artery. So we cleaned it and we put the sheath in the left femoral artery, and we are going to do through this road. As the patient has a distal left main disease also, we decided to take the Judkins left of 3.5 curve. Sister, please can I have the 3.5 Judkins? Thank you. Just I will demonstrate to you how complex is the osteoproximal LED lesion. This lesion actually is starting from the distal left main with a mild block, and thread-like LED is taking origin at 130 degrees from the dimple of the left distal LMCA plaque. In addition to that, this patient is complicated by not having a protection to the LCX, which is a dominant LCX. First we will try with the AGWR. Sister, please can you give the AGWR to me? I think this valve. Yeah, I think we can, the curve on this is acceptable to do the PCI. Yeah, let us see it. I think probably this requires a floppy hydrophilic with a different angulation, the wire. I think probably choice PT may be better in this case. Dr. Lalita, what do you think about it?
Yeah, I do think that we should take a choice floppy here.
Yeah, then let us take the choice floppy. Yeah, and this is the angulation. I think I gave a little bit curvature at the distal thing, and as well as we gave a secondary curve also. I think this we can try to cross it. This curve is very good and it is able to cross it, and with a little bit of turnings we are able to go into the distal LED. That's good enough. And because it is a dominant circ, we require another wire to the LCX also. Oh, there is slow flow phenomena in the LED. Probably the tightest portion of the LED is occluded by the wire. So I think we have to do the coronary balloon dilatation immediately. Now we have to decide the balloon dilatation, what is the size. I think 1.5 will cross very easily. So Dr. Babu, please can you give the 1.5 balloon? Yeah, that's good enough. Thank you.
Yeah, Dr. Jyotsna,
Yeah.
considering that the patient had a pseudoaneurysm and he had to undergo surgery, what kind of anticoagulant strategy you would like to
Yeah, actually
take
this is
up
very
now?
excellent one. Even we are scared of the giving the higher anticoagulation. The patient is already on the DAPT, and we thought we will try with an heparin with an effective dose. And Babu, what is an ACT? We are already giving the 5,000 to the heparin.
Yes, madam.
What is the ACT now?
ACT 256.
Oh, good. It is an excellent. I think that Radhicha, is that okay? Or should we give them some more heparin? I think between the 250 to 350 in a complex angioplasty is unacceptable. If it is required, the further we can give it and we can further test it.
Depending upon the complexity and duration. we will-
Yes, we will do that.
Dr. Jyotsna, from the angio we can see that there seems to be an osteoproximal involvement of the LAD as well. So would you like to do an IVUS or would you prefer covering it up to the ostium extending into the LMCA?
That's true. There are two strategies for osteal LED lesion treatment. One is the stent implantation to simultaneously cover the osteal LED lesion, origin of the circumflex artery, and to the greater or to the lesser extent to the distal LMCA. This entails a further planned intervention to adapt the proximal portion of the stent to the bifurcation and the LMCA, usually by simultaneous inflation of the two balloons, that is kissing balloon technique. Another strategy consisting of implanting a stent to cover the LED ostium with a minimal protrusion in the area of the carina.
Yeah, I think we can stop near the ostium of the LED instead of extending into the LMC.
The problem of the choice is about the type of the stent what you are going to use for this. We used a patient had a BMS with a restenosis and DS is used, and we used the Zinsby. And now relatively there is a patency of the vessel which is stented. So, should we take the same Zinswee or should we take a different one? What do you think, Dr. Aditya? Is there any strategies or anything which will say that different type of the stent or same stent is going to be the better in this patient?
Yeah, the earlier everolimus eluting stent seems to be fine. Probably we could go with the same molecule here also.
Yeah, as Dr. Aditya said it, actually there is a few studies which demonstrates that in a sirolimus eluting stent, the restenosis, we can use the paclitaxel, as well as the paclitaxel induced ones, we can use the limus. But in this patient, the patient had a relatively well preserved previous stented drug eluting stents with everolimus. I think it's preferred to take to the everolimus. The size is going to be 3.5 into 14. Okay, Babu, please get the Zinswee at 3.5 into the 14. Thank you. After the stent implantation, I think it is a good position because it is covering the ostium and not much of a protrusion into the left main, and there is no pinching of the circumflex. I think it is an acceptable result in the end. In unstable acute coronary syndrome patients, it is better to control the bleeding complications with appropriate therapy, like in this case, urgent pseudoaneurysm repair and planning for the PCI as early as possible. Even during the PCI of an osteoproximal LAD lesion with a dominant circ without an IABP axis, we should have a proper planning, like selecting the Judkins catheter guide for the engagement of the left main disease and using an angulated more than 90 degrees distal tip angle and floppy choice wire to cross the lesions gives a success to the case. Thank you.